So we got these problems here. Sorry for the way these screens are looking. Jack things up a little bit. So I put a couple slide sets in there, real short. One on flow and vaporizer problems, and the other one on the alveolar pressure difference minus the venous pressure difference. We'll go over both of those real quick. We've got about 40 slides left to get over today. That'll be plenty of time. So we all remember going back in the sim room and seeing what this looks like. And I would expect a test question. It kind of got knocked over here. But there's going to be arrows pointing to the Thorpe tube at the liters per minute. I'm going to have like certain arrows pointing. I'm going to ask you to calculate the FiO2. And then this dial will be set to a percentage. Expect 3 or 4 of those kind of questions on the exam.
The thing on the left is called the Thorpe tube?
These are called, yeah, these little tubes are called Thorpe tubes. And so you've got these bobbins. Yep. Wherever the top of the bobbin is, that's where you're at. So if I put this, but I'm actually just going to put arrows.
Right, but it's liters on one side, tenths on the left?
Liters on one side and hundredths of liters. So if I'm here, that's 100 mLs, 200 mLs, 300 mLs, 400 mLs, and then that's a liter, 2 liters, 3 liters, 4 liters. So, everybody got that?
Yeah. Say that again,
sir. So if I'm here, the smaller tube on the left are mLs. So that's 100 mLs, 200 mLs, 300 mLs, 400 mLs. The one on the right is liters. 1 liter, 2 liters, 3 liters, 4 liters. Okay. And so, my mic's not on. No wonder. And then on the right, of course, you know that I'm going to put it on a percent. And if percent's on the dial, then MAC is in your mind, right? You have to do that calculation. And on the Thorpe tubes, what's the only one that gives you a MAC value?
Nitrous.
The nitrous, right? Excellent. Oh, bummer, you can't see that. It's going to be kind of hard to do these problems. Can we reset that real quick?
If you just turn the system off, sometimes it comes back on. If it doesn't work, then you have to reset the actual projectors.
That's all right. Bubblegum wrappers and toothpaste will make it work. Sweet. Okay, so this is kind of a practice model for you guys to use. All right, let's go through the first one here. On the yellow dial, what do you know the yellow dial to be? So there's a yellow Thorpe tube, and then there's a yellow dial. So sevoflurane is the yellow dial, the vaporizer dial. All right, so that's set at 1.4%. You've got oxygen here that is delivering 1 liter per minute. And you've got nitrous oxide at 2 liters per minute. So my advice to you is to calculate the total flow on the left-hand side, and then calculate the percentage of each flow. Determine if you're delivering MAC, and then add the sevoflurane MAC onto that. what's the first thing we do? We've got 2 liters of nitrous. We've got 0 liters of air. We've got 1 liter of oxygen for 3 liters total flow. Now we know that the blue Thorpe tube will give us MAC. How much MAC we have to calculate. So we're giving 2 liters of nitrous and 3 liters total flow. 2,000 mLs, or otherwise known as 2,000 mLs over 3,000 mLs. We work that out, and we see that 67% of the concentration is nitrous, or the FI of nitrous is 0.67. And we also know that our MAC of nitrous is 100%. Thus, we're delivering a MAC of 0.67 with the nitrous. We know that oxygen doesn't have any anesthetic qualities, so we don't have to worry about that. But, even though I don't have it on here, what would the FiO2 be? 33%, 0.33. Let's make sure I don't tell you incorrectly. FiO2 is 0.33, but it's 33% oxygen. So now our MAC of SIBO. This is an older slide where I use 2.1. You can use 2.0. You'll get it. You'll get the answer right regardless. So if I take 1.4 divided by 2, that's roughly 0.7, right? So we've got 0.7 or 0.67 here because I used 2.1. Then we know what the next step is, and that is what? Adding them up together. So we're delivering roughly 1.3 to 1.4 MAC. Now, if I want to dial in, I want to turn off my nitrous. My patient's getting hypoxic. The nitrous isn't helping me out, and my staff says, get that nitrous off. I hate it. But I want you to keep the same anesthetic depth. So your MAC is not going to change. Right? You need to get it, keep it at 1.3 to 1.4. So you turn off the nitrous. What do you need to now increase your concentration of SIBO to? So that's a very simple answer. What is your standard dose of nitrous oxide? 2%. And you need to give 1 point. SIBO. Slow down, Bentley. 2% SIBO is your standard dose. I got nitrous on the brain. So 2% is your standard dose, and you want to give 1.34 times that. So what would you increase your dial to? 2.68. You see where 2 times 1.34? That's all you're doing. Because 2% is your standard dose, and you need 1.34 times of that. Now, in this example, these are a couple years old. I actually used 2.1%. I mean, so if you want to make that your own 2%, that's fine. On the test, it will be 2%. I'll let you, well, you got the slides, so you can do it anyway. So, is that helpful? All right, so the blue vaporizer dial is representative of what? Desflurane. What's the standard dose of desflurane? 6. And you're delivering 7.8%. So how many times the standard dose are you giving? 1.3. And you're giving 1.3 MAC, right? So that one was pretty easy. But what MAC are you giving from the Thorpe tubes? 0.5. How'd you come up with that?
Total flow
Check.
is 4 liters.
Check.
So you're dividing the 2 liters of nitrous by 4 liters overall.
That's right. So 50% of your concentration is nitrous, or your FI of nitrous is 0.5, and your MAC is 0.5. And now you add those up. What do you get? 1.8. Well, I thought I had the answers to these. I see why you wanted to know. Gotcha. All right, what about this one? I'll give you a couple minutes, and if you think you got the answer, go ahead and raise your hand. Brian, 0.69. How'd you come up with that? So the MAC of isoflurane is 1.15%. Check.
So 0.8 times
0.8% times 1.15?
Divided by.
Check. So it should be 0.8% divided by 1.15%. That should give you roughly 0.69.
7.
Now, are you given any anesthetic quality from the Thorpe tubes? No. But what's your FiO2 here? First thing you say, even if it's not on, air has 210 mLs of oxygen. That's the first thing you say. I've got 2 liters of air. So I have 2 times 210 mLs of oxygen in that air. And then, so that's 420 plus, I'm delivering another 2 liters. So that's 2420. Everybody see those numbers? Divided by what? 4 liters total flow. So that should be roughly 0.605 as your FiO2. Still see I'm still sick. I think a little bit. Yeah.
So you can figure all that out because it's a closed circuit, right? You know exactly how it's your and what I keep getting hung up on, and maybe it's not there yet, but like, is the idea of only giving 4 liters total, is that liters per minute? Or
Yes, liters per minute.
4 liters per minute, or like, it doesn't sound like a lot. And then thinking about what total volume.
It's actually pretty much so.
Is it that total? Is it
Yeah.
just some of these are like,
What you might call it requirement of oxygen. 250 mLs. Because I have to look at it in that context too. Because you're breathing 20. Are you breathing? Think about air. If you're at minute ventilation with air, it's 5 liters. How many liters of oxygen? 5 liters per minute. How many liters per minute of oxygen are you breathing? About 1 liter per minute. Because your FiO2 in air is 0.21. Everybody see where that one came from?
What was the number that you said was metabolic?
250 mLs.
That's metabolic.
circuit, and that's why. Trying to break something up into it's never gonna be the same.
Well, you've got the semi-open circuit, which you're always going to have the air coming in at a constant rate. So at 4 liters per minute, but you're not breathing. You're not going to overbreathe that. 4 liters, actually 2 liters per minute is just fine to run your flows at.
Wouldn't that depend on what your FiO2, like the smaller amount of the total volume of the oxygen, right? You have a certain requirement of oxygen per minute.
250 mLs per minute, which is a quarter liter per minute.
So right, at what point is there like you weigh this many kilograms, you weigh this many?
So you're getting into. So how do we know what the patient needs? You're going to give 4 to 7 mLs per minute, right? 4 to 7 mLs per kilogram per minute. That is your average. But if you need more, then you increase your oxygen concentrations. If you don't need as much, so now you're getting into that art of anesthesia that you'll be learning about.
The concept there in that case of the release the O2, we can't leave just the O2, we have to dial down on our MAC because we have concentration of what we're giving, otherwise we're going to increase the MAC.
No, you're not. Because remember, this is only adding. Because this comes over, whatever this total flow is, it comes over here and picks up 0.8%. So regardless, that's all you're getting in the mix is 0.8%. or at least in that example.
If you dial up your air, your oxygen, you're messing with nitrous.
Yes, yes. The only one that will be greatly affected would be your nitrous, since it's liters per minute flow. It's part of that Thorpe tube system.
That was the case, then if you have something that's under nitrous and you're getting hypoxic, and
Yep.
you want to increase your oxygen, you have to now decrease your nitrous because you're increasing your
So if you decrease your nitrous and you were counting on that for some anesthetic effects,
increase your nitrous.
okay, so you increase your nitrous.
with your O2. So wherever your O2 goes, if you're going to maintain the same mass, you're going to increase your nitrous and increase your O2.
Yep. You got it. Okay, 0.58%. I put this one just for giggles. What's your max?
I mean,
A little bit less than 1, about 0.9 something. Are we starting to get this? What Mac are you given here? 0.75. See how quickly you're starting to get these? Right, 4 liters total flow. You're given 3 of that is nitrous. 0.75. There you go. How about here?
1.79.
Yes, sir.
Can you go back one slide, sir?
Right there?
Yeah, so if I increase FiO2 by increasing up, I just want to make
I
sure.
know. But if you have an increased FiO2, you're going to increase your oxygen, not increase your nitrous, and you'll use something else that you have.
Because I'm gonna lose my mass.
That's all right, but that's part of it. If you know that you've got to adjust something on your flows and it's going to alter the concentration of agent you're giving, whatever that is, either the patient needs it or the patient doesn't need it. And plus, remember, you're not to the point where you've got other things that you can give. You're learning this in it by itself, right? And this is just, but you're absolutely right. If I got changes in my FiO2, in my O2 demand, not my FiO2, if I have changes in my VO2, I may have to make changes in my liters per minute, okay? Because I'll have to increase my concentration of oxygen at the same time decreasing my concentrations of nitrous. With that, you will get there. You'll get there. How about this one?
0.79.
So you took 1.6 and did what with it?
Divide 1.15, which is
Okay, and you came up with,
ISO.
and you came up with 1.79?
Or once you have to calculate the MAC for E2O as well.
I'm sorry, what was his name?
No problem. First thing we do, we got 5 liters total flow, 2 of that is nitrous, so our FiO2 of nitrous is what? 0.4. Therefore, our MAC of nitrous is 0.4. Next thing we do, we know that that air, or that Thorpe tube mixture is going to go over and pick up 1.6% of ISO. So 1.6% of isoflurane is what you're giving, and what's your standard dose of ISO? So 1.6% divided by 1.15% yields 1.39. Plus your 0.4, because MACs are additive, now you have 1.79. What's your FiO2 here? Well, if nitrous is 0.4, then our oxygen has to be 0.6.
FiO2 is 0.6 max.
All right. Last one. Who said that? Excellent. You're delivering 1.5 Mac here. Can everybody just see it? You didn't even have to calculate. You just looked up there and you're like, 1.5. That's exactly what you're doing in phase 2. For the mess of the dial, I'm going to ask you to turn around. What Mac am I giving? What's my FiO2? Blah, 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 blah. How about the PA/PV slides? Do you want me to go over those? Okay. Or at least starting to feel a little FA FI curve. That FA curve, that FA is your end tidal agent concentration divided by the concentration of the agent that you're inspiring. And when we don't have gas on, there's nothing there. It's zero. Okay? But we prime our circuit, and you take a deep breath. And in this case, I got purple molecules, so let's imagine iso here. So you've primed your circuit full of isoflurane. You take a deep breath. Do you see why that immediately spikes, goes straight up? That slope goes straight up because your concentration in your alveolus is skyrocketing. Okay? And then you start to equilibrate with the blood, and that's where you start to see the bend. Why do you start seeing that bend? Because those molecules are being pulled out of the alveolus by the blood. Right? And then it's going to kind of stay that way, stay bent, and not really rise up until you start filling up the body. Oh, the battery's back. And then it's going to keep slowly rising up on that asymptotic curve. And then you're never going to get to 1 unless what happens? Yeah, what you're delivering. You're never going to be at 1 until what you're delivering here is equal to what you're receiving. So you'll never fill this alveolus up until you've filled up the venous system. And if I could expound those curves, it probably would take 12, 24, 36 hours till you could get to 1. Helpful? Good? All right. And where did I leave off? Now, one thing, real quick, when it comes to the catecholamines and inhalational agents, the thing that I would like you to remember that desflurane indirectly increases your catecholamines. All right. All the agents are relatively safe in regards to ectopy and the use of epinephrine, because I was re-listening to the lecture and I don't want there to be any confusion. Again, the question I'll probably ask this year is, if a surgeon is 70 years old and still practicing, right? And he says, how much epi can I give? And you say, well, I don't know, sir. We're not using halothane, but if we were, I'd have to look up this equation called Vickers. That's the point there. All right, now let's go look at these inhalational agents and their effects on various organ systems. So you're a volatile anesthetic, and what is your job? Put people to sleep, right? Quiesce them, slow them down. So, if I quiesce your neurotransmitter system, which includes your autonomic nervous system, what do you think is going to happen to the release of your hormones from the brain? Slow down. Okay. Slow down. You would think so. But here, for some reason, it seems to go up, the vasopressin release. How could that be?
Baroreceptors.
Sure, that could be part of it. What else could be part of it? So pressure changes. Yeah, we got the baroreceptor. That's going to be like your hours. But what are you doing with the positive pressure ventilation? The cardiac output. You're decreasing it a little bit, right? You increase that intrathoracic pressure, you're going to decrease cardiac output, and then the baroreceptor takes over. So it kind of offsets the effects of the inhalational agents. But for some reason, vasopressin release can be stimulated by some of these inhalational agents. Now, if I inhibit some centers of the brain, can you see how that other centers could be activated? If you don't put the brakes on your car, you don't slow down. Some of the areas of the brain, the job is to put the brakes on things. And so it could be, I'm just speculating here, it could be that the inhalational agents inhibit certain areas of the brain preferentially and allowing others to be active. That's just speculation. But you will see urinary output decrease with the use of inhaled agents. As well, you'll see the urinary output decrease with positive pressure ventilation. Anybody here not that familiar with positive pressure ventilation? No problem. You've got this thoracic space, and you're a negative pressure breather. That's what happens. You drop your diaphragm, you create a negative pressure inside. That actually increases your cardiac output because you're like vacuuming all of your blood from your vena cava into your heart. But think about breathing the opposite way now. I'm forcing oxygen, air into your body, and I'm actually increasing your interthoracic pressure. Now I inhibit preload, decrease cardiac output, and thereby decrease perfusion. If I decrease perfusion, what happens to my GFR, my glomerular filtration rate? It will go down. And what will happen with my urine? It will go down. All right, we're getting to the clinical board questions here. Fluoride ion production. Fluoride ions are a byproduct of metabolism of these agents. All agents will produce them, some more than others. What do we know about the metabolism of sevoflurane in the body? What percent? 5% of it is metabolized by the body. That means it's making fluoride ions. Okay. The old agents, the methoxyfluorane, right, for example, you could run that for a day or two, and you could actually kill the kidneys. You could actually kill the kidneys. It was nephrotoxic. So what this graph is showing you here, you look at your waters, and you see your serum fluoride in micromolar. That's just a measure of concentration. And then, in this example, these animals had days and days and days of anesthesia. Is that what that's saying? Can you agree with me? This is a patient on the bottom. Right? Here's fluoride ions were drawn pre-op. Their anesthetic was conducted, and then they were monitored days after the anesthetic. And so, as a result of the delivery of either methoxyfluorane, which is in blue, an old agent, and fluorane, which is in orange, isoflurane, which is in this yellow diamond, sevoflurane, you can just kind of barely see it, and then at the bottom was desflurane. What is that graph saying to you? Okay, so with the modern agents, so if I say modern agents, you're thinking 3. Which one increases fluoride ion concentrations? Sevo. Now, this is another calculation that you saw earlier, and we just haven't calculated yet. So a Mach hour is, if I run 1.5 Mach times 6 hours, how many Mach hours have I delivered? 9. That's all that is saying, 1.5 times Mach hours. All right. Now, if I am worried about fluoride ion production and nephrotoxicity, I don't want to run methoxyfluorane more than 2 to 2.5 Mach hours. That's just a historical question. I'm not going to ask you that, but you can see how toxic older anesthetics can be. Look at enflurane. I'd have to run that for 9.5 hours. But sevoflurane, I would have to run that at 23 Mac hours. So that could be I could run 2 Mac for what, 12 hours? I could run 3 Mac for 8 hours. I could run half a Mac for 46 hours. Yeah.
So do you worry about this if you have to take a patient back to the OR like the next day or something like that?
No. So this is what, just so I understand it right here,
Sure.
right? They gave this to animals at what? For
No,
how long?
I was just seeing if you're paying attention. No animals, real people. Real people.
They gave this to humans for how long and at what max?
So I believe it was just for the procedure, a 1 to 2 hour procedure. Now, just because this is high doesn't mean these are toxic concentrations. It just means that they're high amounts of fluoride on it. That's all that's saying.
So we really don't run into issues until we hit 23 hours of MAC hours of SIBO. So,
Right, that could
but
be.
in terms of a board question, yes, SIBO makes fluoride ions, which may make it difficult to concentrate your urine.
Here's the board question. Which of the following agents increases fluoride ion production within the body the most? SIBO. If we're talking, I don't anticipate methoxyfluorine being on your exam. That drug hasn't been used for 40 years.
What was the MAC hours again?
Yeah, MAC hours. Here's a question. I'm running 7.8% desflurane for 7 hours. How many MAC hours am I running?
You said 7 hours?
Yep,
7.8?
7.8% times 7 hours. 9.1 MAC hours. I run half percent. No, I run. Let's see. I run half percent SIBO for 10 hours. 2.5 MAC hours. Right? Because if I'm running half percent SIBO, 0.5 divided by 2 is 0.25 times 10 is 2.5 hours. So that's a MAC hour. So renal effects. What do we know? Does urine output decrease? Yes. Is there fluoride ion production? Yes. What do fluoride ions do to the kidneys? They hurt it. If you have the toxic concentration, yes. So, yes.
So if you're manipulating the flows and stuff on your SIBO, your test, whatever you're running, then how do you figure out MAC hours from that? If you're actually
Flow has nothing to do with MAC.
Well, I mean,
Only in the regards that you're changing your percent of nitrous if you're using it.
well, I guess if you're for a little while you're running 1 MAC a test, and then you
Sure.
go down to half MAC, and you go back up. Because then I've seen the CRNAs get twist happy.
Yes.
How do you figure out your MAC hours then? Do you
Remember,
just-
this says 23. Is this probably clinically relevant?
No.
No.
Okay.
Absolutely not. This isn't clinically relevant. We'll get to compound A production, which is. But we'll talk about that. So we know that the kidneys are affected. How about the liver? Well, if I'm a volatile inhalational agent, I drop your blood pressure, right? Because all of them do it. All of them do it in a dose-dependent fashion. I'm going to decrease perfusion to the liver. That's not a. If I decrease perfusion to the liver, what do I do to the metabolism of your other drugs? Right? I can't deliver the drugs to the liver as quickly, so I increase the half-life of your other drugs. Right? We also talked about the hibernation ability, the theory of these inhalational agents. So if I can slow down your energy consumption and your energy production, I can slow down your synthetic factories, right? I can slow down the activity of your enzymes. So the two big things for the liver. What does it do to liver perfusion? It decreases it. And then all of a sudden I'm surprised because my Versed has lasted an hour and a half instead of 60 minutes. Why? Because I have A, decreased liver perfusion and decreased activities of liver enzymes. Tracking? So make sure you understand that the half-life of drugs are increased while you're using these agents.
What about after surgery?
Well, once you get rid of the agent, then you'll get rid of the effects. And what's the only way to get rid of these agents? You've got to breathe them off. Skeletal muscle relaxation. Now, if you remember, what are the two things that are the absolute requirements for an anesthetic state? Akinesia and amnesia. The two must. Okay? So if I'm a volatile anesthetic and I want to keep you from moving, where is that mediated at? I'm this volatile anesthetic molecule, and I got two choices. I'm either going to go to the brain, or I'm going to go to the spinal cord to keep your muscles from moving. Spinal cord, because immobility is regulated at the spinal cord. All right, that's what this graph is reflecting here. This, who here has used a train of 4 monitor? Who here understood what it was when you were using it? If you go to my YouTube channel, I have 2 very nice videos that explain the train of 4 in like 3 to 5 minutes. But here's a quick synopsis, so you can at least understand that graph. When I use a muscle relaxant, and yes, it can be a inhaled agent, I want to check the strength of my muscle. So I will place on the ulnar nerve my electrodes, and I will look after I stimulate to see the response that I get. Have you had the skeletal muscle physiology yet? So now you're starting to understand that you give that electric volt, and it causes the action potential, which causes the voltage-gated calcium channels to open at the synaptic terminal, and that calcium starts to influx inside of that nerve terminal, and does what? It releases the acetylcholine, right? It interacts with the snaps and the snares, all that stuff you're going to have to learn. The acetylcholine gets released, and bam, you get a twitch. All right? And the rest of the calcium causes the next round of vesicles to mobilize. And so with each twitch, it measures the ability to both release and mobilize acetylcholine vesicles. Well, if you interfere with it, so that's all you need to know right now. So if you interfere with that ability to both release and mobilize acetylcholine vesicles at the nerve terminals, at the neuromuscular junction, you're going to see this phenomenon called fade. So for our purposes, that's really all you need to know here. And what is that graph telling you? That graph is telling you that I am getting a certain amount of fade, or muscle weakness, at varying MAC concentrations, which goes to prove that there's a direct skeletal muscle effect from the inhaled agents. Does that make sense? If not, let me know. And in regards, when you see these equal signs, this means that they're all the same, right? And it does. They do it all equally. The modern agents do it all equally the same.
Excuse me, so they're just at a MAC of...
So 100% fade means you get no response. 0% fade means you have a full response. So this is a full response on your train of 4, if you want to look real quick. Bam, 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 bam. Okay? If I have fade, I could see one strong one, and then it goes away. That's fade. If I have 100% fade, I activate it. Bam, 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 bam. I get nothing. Okay?
So a higher MAC will lead us to a higher...
So a higher MAC relaxes your muscles quicker. Yes, absolutely. When it comes to the aqueous humor inside of your eyeballs, the inhaled agents will decrease the production of aqueous humor, allow the drainage of aqueous humor. I know you haven't learned about the eyes yet. Don't crucify me for it. Just know that intraocular pressure will go down when you use the inhaled agents. Because, think about it, if I am an inhaled agent, I am going to slow your metabolism down. I am going to slow your enzymatic reactions down. And how do you make aqueous humor? Through a series of enzymatic reactions.
Is that why people get corneal abrasions during surgery?
No, people get corneal abrasions because we forget to tape their eyes, and they have the inability to tear, so their eyes get dry. And what do? We lean over them with our necklaces on, and they get up. And why do we put the pulse ox on the second and third finger? Because the first thing they do is start rubbing their eyes. So we forget to tape their eyes. That's on us. Okay. Uterine effects. What do you think, just intuitively, that inhaled agents do to smooth muscle? Relax them. Exactly. Yes. We've already showed that these agents will relax respiratory smooth muscle, bronchial smooth muscle, and smooth muscle is smooth muscle. The uterus, when you use this, it will relax the uterus. I know you haven't had OB yet, but envision this. We all know that the uterus is about this big when it's non-gravid, and it has about 60 mLs to 70 mLs per minute of blood flow. But then, full term, it's pretty good size, and it has 600 to 700 mLs per minute of blood flow. You get called back for a stat C-section, someone that just came in, and you've got to put them to sleep now. There's no time for a regional. So you think about this, and you're like, good God, there's a lot of blood flow, and my inhaled agents are going to dilate my uterus, making it worse. Why does it make it worse? Because smooth muscle relaxes, and we need it to contract in this case because the placenta has separated from the wall of the uterus and left these open vessels. And so we need that uterus to clamp down on those vessels. So you think that to yourself, and you're like, I'm trying to use as little agent as I can. And that's just in the back of your mind. So if you can remember that scenario, that, man, if I'm using inhaled agents, my uterus is going to relax. And whatever my uterus does, my bronchial smooth muscles will do. So if they're an asthmatic, not pregnant, that's good. But if they're pregnant, and we go back for a stat C-section, that's not so good. But what else do we know? We know that we could probably offset the effects of the inhaled agents by using a nice gas that gives us MAC from our Thorpe tubes. Yep. Nitrous oxide will offset some of those effects and causes an increase in uterine contractility. The mechanism for that is not as clear, but the effect is real. So a question could be this. You get your patient to sleep, and then you can have one MAC on, right? And it could be one MAC of isoflurane by itself, 1.15%. But then baby comes out. What might you want to do at that point? Maybe switch to an IV agent or decrease your concentration of isoflurane by replacing it with nitrous. Good.
Could you start the case with nitrous on board?
In a situation like that, would you want pitocin?
One,
Too far.
too far. Pitocin, yes, works. Not there yet. Take this one concept at a time. Right. Yes, you give Pitocin, but don't think. I just want you to think about this in a vacuum.
Would you start the case with nitrous on board?
You wouldn't, but why would you probably not induce a stat C-section with nitrous on board? Well, plus they're going to desaturate quickly, and it takes too long to work, and you're going to give them propofol on induction. So I like the way you guys are forecasting, but don't learn too much too quickly because you will confuse yourself. So take all of what you know and have ever learned in the past and just throw that stuff right out the door. One concept at a time.
What is BDZ?
Benzodiazepine.
Benzodiazepine.
BDZ is benzodiazepine. Because those are the kind of comments, even though I know you're intelligent, but when you go to take your exam, you're asking all these what ifs. And what do we do as instructors? We're trying to distract you with not true what ifs. Right? So if you're thinking of imaginary words that are not part of that sentence, do not include them in the sentence. Nitrous. Is this potent? It is not. Not potent. And did we have everybody get my mistake and change it? This should be 100%. 1 MAC is 100%. Does it have analgesic properties? Yep. Much greater when you relate them to iso, SIBO, and DES. Much, much greater. So if I know, check on learning, if I know that uterine smooth muscle will contract with nitrous, I also know that what other kind of smooth muscle will? Bronchial, vascular. So would this help offset blood pressure issues? If I'm using a lot of SIBO or a lot of desflurane, and I see that the patient is starting to drop their MAP, right? Because all inhaled agents will drop MAP in a dose-dependent fashion. So I could turn down my volatile concentration and turn up my nitrous, assuming the patient's tolerating it, to offset that drop in blood pressure. Tracking? And do you understand what I mean by tolerating it? Sometimes, if you turn on nitrous in some patient populations, COPD, emphysema, some of the respiratory cripples, they don't do well sometimes on nitrous. You'll see them desat very quickly. So here's that concept. If I give a mixture of nitrous and isoflurane in this example, I will see less of a blood pressure drop than if I just give isoflurane alone at equipotent max. Okay. Take a break because this will take a little bit of time. Come back in about 10 till.
So if we need to get 5 minutes. Induce.
You always use propofol.
And then switch to 1 MAC.
Well, if you use the propofol, remember that's going to last 7 months. How long do you take the statin C-section? So, while it's wearing off, you just crank with a little bit of
It's like SIBO or something like that. Okay. It slows
All
you.
the answers, and then second, but not in the first day, the read it. I just took it a lot more. Seriously, put it in the first few days. So,
I just wish you said there at the end about it. When you said helps blood pressure, I don't know if it was helps blood pressure.
helps to maintain.
That's too much going
So if
on.
I give
I'm
you,
working on low blood pressure.
well, here's, think about this. You're 120 over 80. I give you a MAC of 80, your blood pressure drops to 80 over 60. Okay, I give you a MAC of 6%. So I decrease the dose to 3%, 50% nitrous. Your blood pressure comes back up to 100 over 70.
That's what I was thinking. That helps blood pressure.
We're thinking the same way.
So
But yeah, that's not always true at phase 2.
my doctor wants my blood pressure to be lower, but you know.
Oh, yeah, I'm on cynical.
So you say lowers blood pressure.
5 years here has really hurt me.
I was just saying it'll kill you.
Your handwriting is
Oh, because it
Oh, thank you.
becomes your normal floor.
I ended up typing it first on my copy because I didn't
I kind of agree that you should have had people to become much more. But, it's just what it comes to. So.
know exactly what you got. I remember, going into my neuroscience lab for the very first time, and I had never picked up like that. I had never done any of those scientific analyses. I had never done any of that stuff. I was like, good God.
If I couldn't get out of here.
In 4 years. Well, my colleagues had 7 years.
Oh,
I only had 4 years because that's what the nurse corps said. Yeah. But like, if a foreign language, like reading journal articles.
Or you have to take every word and go look it up in the dictionary because you're like, what's that mean again?
And at that level, it was ridiculous. You taught yourself at that level. You didn't really get taught. I could do a mean Western blot confocal microscopy.
So, sir, you said you might do a review on Monday?
As long as my wife gives me the okay, I will.
That's no, I'll be here. I'll be here. Whatever time is good for you.
Is it hot in here? Is it just me?
It's always my
So, sir, if we just keep practicing, because I mean, I can make up questions for myself on math now.
Yeah.
Like the same, you just keep practicing that type of stuff.
Until it comes secondhand. Exactly. Until you know in your head 1.152 and 6, 1.152 and 6, 1.152 and 6. And then it's amazing once you start working with your torque tube so much, you just know what it is when you look at it. You're like, I know exactly what that is.
Nitrous isn't shunting with the COP meters.
This actually might be part
Well, this one would be basically just changes to 6 years.
increase in compliance rates to 5 pressure. Not compliance rates. Getting into
It would be 1.5 max.
I know, I haven't watched that. Myself, we have to like move off the map.
But that's too multi-level.
Sports teams that pushes on them.
I got it covered everywhere except the Southwest, except I'm living here now.
Turn your fan up and make yourself cold.
I'm from everywhere, sir. I was born in New England, raised in the southeast of North Carolina, reside now in the Pacific Northwest. My wife is from Minnesota, so I got the middle of the country.
And the security clearance people think you're from Colombia.
Oh yeah, and so South America thinks too.
That's awesome.
I think I saw you in Clear and Present Danger on the rooftop.
Yeah, exactly. Since you're gone, it's a large mistake. Yeah, exactly. It's all moved up to Mexico. Yeah. You shouldn't do that.
I saw one of the places I know. The food.
And they were names?
Yes.
Yes.
Parts unknown.
Parts unknown.
There's some places
Yeah, that's what people told her.
Oh, it's okay. I went for Wilson's company.
Start time.
It's because that's where it's produced. But it's sad because there's no money in it. It's like these farmers are putting their lives in places to make it so that they're not just going to go for this stuff. They're all in Mexico now. Trying to get out some.
vasopressin levels up or down? Okay. Vasopressin levels in the body, up or down? You would think it would.
Urine output goes down. Right. Yes.
He's so robust.
No, no, it seems funny that the thing about urine output says you have to suppress all the systems.
There might have been some confusion with until and then it breaks.
No, it's cool.
Okay.
Okay, here we go. Now, this is a concept that is important. And this is a reason that many people won't use nitrous in certain instances. And it has to do with its solubility. This has the capability to be more soluble in blood versus nitrogen. So N2O compared to N. So you turn on nitrous oxide, and I want you to imagine your bowels. Okay? That's strange, sir. Yes, it is. But your bowels, are they compliant? Yes, they're very compliant. And you run nitrous oxide into your bowels for 6 hours. What's going to happen to your bowels? They're going to fill up with nitrous oxide. Okay? Why are they filling up? They're compliant, right? And as the nitrous goes in, guess what comes out very slowly? Nitrogen. So you're adding nitrous to air, and the nitrogen that hopefully would leave doesn't. It doesn't diffuse very well, at least in relation to nitrous. So nitrous can get in faster than nitrogen can escape. And why am I saying nitrogen? Because what do you give in your Thorpe tubes? Usually O2 and air. Or O2 and nitrous. You'll use air in certain circumstances, but if you're in my OR, you'll use usually nitrous and oxygen combined together. Now, if you're in someone else's OR, maybe they turn on the air to decrease the FiO2 delivered to the patient. Because you may have heard about oxygen toxicity over hours and hours. Some people do not like to run a very high FiO2. Well, I solved that problem, and I give 50% of my mix is usually nitrous oxide, and the other 50% is oxygen. So I have a lower FiO2. But I want to fill up all of my spaces with oxygen. So what do I have to displace? Nitrogen. So I've got oxygen and I've got nitrous oxide going to places, right? And it's starting to fill up these spaces. Your intestines, for example, they're starting to get bigger. Why? Because the nitrogen, it's hard to displace that out of that space. So what happens to the volume of the intestines? They puff up. Okay? Now that's like 6, 7, 8 hours of nitrous. Now think about that same instance in your brain. What's the difference there? The brain is not compliant, so what's going to happen inside? So the accumulation of nitrous oxide in an airspace that is in a closed vault. The airspace gets bigger, so imagine you have a bubble in your brain, and you have a closed head, the skull is closed. And in this theoretical concept, you're delivering nitrous oxide to a closed head injury, and maybe there's an air bubble in there or something. And what is going to happen to that air bubble? It starts to increase. And what happens to the tissue surrounding that increased size air bubble? It starts to get compressed. Why? Because intracranial pressure has risen. So what have we learned about nitrous if given for an extended period of time? It will do what to non-compliant spaces? Make them non-compliant, he's right, non-compliant spaces. Increased pressure. Compliant spaces. Right? So non-compliant is pressure, compliant is volume. Non-compliant pressure, compliant is volume. Now think about some of these spaces that you have that might be clinically relevant. Okay? Think about some of those spaces. So the next series of slides are just examples of what I just said. Now these are some of those spaces. So let's think about this. Has anyone ever taken care of a patient that had a spontaneous pneumo? Usually they're tall, lanky guys. They don't really know it. Now imagine that guy on your OR table. Have you had one? And now imagine you on the OR table with this pneumothorax. Maybe it just started. Maybe you didn't. You never had one? Usually it's the tall, lanky guys.
I have to.
Yep.
I had a SEAL officer who had just finished running a marathon and said he had minor chest discomfort.
And he had a pneumo.
Like complete collapse of one entire lung.
Now imagine giving nitrous oxide into that pneumothorax. Okay, so let's just take this picture. Someone is spontaneously ventilating in your OR. You have a mask on them. And they have this pneumothorax. It starts to get bigger and bigger with the nitrous. What clinical sign will you see? So physical sign. Tracheal deviation. To which side? Away from the pneumo. Right? That's the cardinal question. Pneumothorax, tracheal deviation away from the pneumo. Now think about doing, anybody ever work with EENT surgeons? The kids. The ear that's a closed space. The ear is a closed space. So you may have a request to use nitrous oxide. Can you think of a situation with kids and ears that you would actually want to increase pressure inside of that area for a little bit? So you have that eardrum, and sometimes if it's retracted, with these kids with chronic infections have, like my daughter, you may get a request to use nitrous so that membrane bulges out and the surgeon gets some exposure. That might be an example. All right. We talked about the brain. One thing we haven't talked about is the sitting position, and you'll have a class later on, but let me explain that one. So you're doing neurosurgery. You have a patient in the sitting position or in the semi-recumbent position. When you remove the skull, what do you know about the veins in the skull? Do they collapse? No. They stay dilated. Why? Because they're attached to the skull. They never collapse. Now, if the head is higher than the heart, and you have these veins that can't collapse, what is a potential problem? Air embolism. Right? Because if the head's higher, that's a negative pressure going in towards the heart as the blood is pulsating around. So now we get an air embolism. And if we're using nitrous, what could happen to that air embolism? It gets bigger. And then we kind of mentioned the laparoscopy in regards to bowel. If you're having an 8-hour laparoscopy, you probably got a first-year surgical resident doing laparoscopy. But the point there is, if you use nitrous for a few hours in the laparoscopy, you might see your bowels start to increase in size. Not only your bowels, but if you're running nitrous for 3-4 hours in some cases, what do you think happens to your endotracheal tube cuff?
gets bigger.
What do you fill it up with? Air. And nitrous is very diffusible, right? It'll go through plastic, it'll go through lots of things. So what happens to the pressure inside of your endotracheal tube cuff? It goes up. So you may have to release some of that pressure after a couple hours. So I think we get the point on nitrous oxide.
Why cerebral ventricles?
Okay, so that's because they're in the cranial vault. Because there's not much space for things to change inside of them. If the liquid volume increases, what happens to the tissue on the outside? It gets compressed. If there's an air bubble inside of the ventricles, as it's quite easy to have air bubbles in a liquid solution. You have, believe it or not, air bubbles floating around you all over the place. Some bigger than others. Inside the ventricles, if you have these tiny, tiny bubbles that could, in theory, increase in size. Tiny, tiny bubbles in my wine. Yes. Oh yeah, POMV is postoperative nausea and vomiting. There is not a lot of good evidence that says nitrous is connected to it. But some of you, in a few years, will hate nitrous, and some of you, in a few years, will love nitrous oxide. I love it. So, there. All right, you're at the end of the case. So you're on the downslope of the mountain, and you're starting to dial back your inhalational agent. Your patient is spontaneously ventilating. And you remember that Dr. Bentley told you that he likes to use nitrous at the end of the case because it gives some MAC, and it's a good analgesic, and it allows me to get the gas off of the patient. But the thing that you have to remember is that at the end of the case, once you turn off your flows, nitrous is very diffusible, right? So you got all this nitrous oxide floating around in your body, and as soon as you turn it off from the Thorpe tube, it's not very soluble and it's very diffusible. Think about that combination. So now you got a gradient inside of the alveoli of no nitrous oxide, 0. And your blood is full of nitrous oxide. Where's it going to want to go now? And what is it going to do to the gases inside of that alveolus? It's going to displace them. So, if you do not compensate for this by increasing your oxygen flows to 6, 7, 8 liters per minute, and in a healthy person, let's just say you turn everything off and let them breathe on their own to try to blow this off, you're going to see your pulse oximeter drop transiently until all of the nitrous is gone, and then it's going to come back up again. That's called diffusion hypoxia.
How low did you see it drop?
Oh, you 80, 77. It'll make you pucker a little bit.
How long do we have to keep it going?
Yeah, it's about 10 minutes is the rule of thumb you want to use at the end of the case. But I'm here to tell you clinically 3 to 4 minutes. 3 to 4 minutes.
So heading that off with the oxygen, increased oxygen flow should eliminate that.
Now a way to, so remember, you've got nitrous oxide that is coming from the blood into the alveolus. So it's trying to force its way in. So what do? You try to force oxygen down. And that will help just get you some oxygenation while you ventilate off your nitrous. Absolutely. So does everybody have a clear understanding on diffusion hypoxia? Yes, sir.
Are you saying that they'll have that even if we turn on the oxygen, or
They should not. If you compensate with a high liter flow per minute of oxygen, you should not see this. If you are a rat, that's a joke. But anyway, nitrous oxide in pregnancy, probably not a good idea in the first trimester. Probably not a good idea legally for the entire pregnancy. Now, in animals, it appears that DNA synthesis is inhibited because nitrous oxide will inhibit this enzyme called methionine synthase, or synthetase. And that enzyme, excuse me, will create methionine, right? And then that methionine interacts with other substances for DNA synthesis and maturation. So, there's another board question. Methionine synthetase is inhibited by nitrous oxide, which will interfere with, nitrous will then interfere with DNA synthesis. Here's halothane, see it? Bye. Here's enflurane. When I say enflurane, you say, thank you. ISO. Perfect. Most potent, we'll give you a series of questions. What is the most potent modern anesthetic? Isoflurane is the most potent. What has the highest MAC value? Desflurane. Correct. Don't screw up the potency. What is a good choice with the modern agents for an inhalation induction? What's the worst choice? That's right. Why does your heart rate go up with desflurane? Especially when you change concentrations quickly? So it has an irritant effect, right? There's these receptors that are actually recalled irritant receptors that are irritated by desflurane. And your catecholamine levels rise. And you start to spit, sputter, spew, tachycardia, hypertension. Why does desflurane need a special vaporizer?
Vapor pressure is almost the atmosphere.
It is. What does that mean?
It doesn't want to readily diffuse into a gaseous state. It needs to be heated to reach the gaseous state.
It needs to be pressurized and heated to keep it in a liquid form. It needs to be pressurized and heated to keep it in a liquid form. Because as soon as you open up that bottle, it's gone. It's gone. Even more so than ISO and SIBO. I mean, they have vapor pressures and they'll evaporate. But when you get to phase 2, well, tell them I told you to do this, but take a little SIBO, dump it, watch it. And it'll never reach the counter. Yes?
Is there maybe if you cool, like, pressurize and cool to keep it in a liquid state?
Well, I think heating it allows for a greater pressure to build up, and that's why they do it. So their vaporizer is heated and pressurized. It's called the Tech 6 vaporizer. So we're not there yet, but if you want to learn about it, the only thing I need you to know is that it has a special vaporizer because of its vapor pressure. And its vapor pressure is at least 3 times that of the other two. But the Tech 6 vaporizer, you want to learn a little bit about that. It has to be heated and it has to be pressurized. Both have to happen. Because, can you take a desflurane vaporizer with you in the field? No. You could, but you'd have to have a constant supply source because the vaporizer is the only one that needs an outlet to work. It has to be plugged in to be heated. Sevoflurane. Oh, one more thing on desflurane. It's not on here, so pay attention. If you were concerned with carbon monoxide, and you wanted to pick the worst offender from the list of modern anesthetics, it appears that desflurane, when it interacts with the soda lime, everybody know what that is? The soda lime is that little white mesh that scrubs up all of the CO2 on the side of the anesthetic machine. It looks like cat litter, but if you take it home and your cat uses it for cat litter, you'll burn the crap out of the bottom of their feet. It's very basic. So when desflurane interacts with that mesh, that white stone barrel line, it seems to create carbon monoxide. So carbon monoxide levels in the blood may go up. Make sure you write that down. Yes, desflurane, yeah. Desflurane. Sevoflurane. We said it was very sweet. And now compound A rears its ugly head. Compound A. Anybody know what that is? While you're up there, sir, tell us. Sometimes you know. So that same soda lime, right? Those granules that scrub the CO2 from the circuit. Well, when sevoflurane interacts with that soda lime, a compound is developed. 3 of them, right? A, B, C, and I think a couple others. But compound A is problematic because it will kill the kidneys. Yes?
I understand the combination with 7-Eleven. How's it getting that with patients?
Because you breathe it in.
So it's a close contact.
You're using a semi-open or semi-closed system because what you don't know yet is that the pressure valve on your circuit will dictate how much of it you open up to the patient and how much of it you keep closed to the patient. But you haven't learned that yet. But say you have a semi-closed system where the patient's rebreathing some of their own stuff, like in low flows, for example. Well, the sevoflurane could interact with that mesh, that CO2 scrubber, that soda lime, and create this compound. And then when you breathe it in over a significant amount of time, it could hurt your kidneys. It could. And there's more to say on that. Are there any questions I might ask in regards to metabolites and the agents?
Sir,
Yeah.
on this fluorine, it says may increase NE release with NE.
Norepinephrine.
Is there any play with other absorbers other than soda lime?
Well, there's 2 choices typically, barrel lime and soda lime. And soda lime is the main culprit usually.
On the slide before, it just said,
Okay? What do you know about all of the modern agents? They're all ethers, right? Except for halothane, which is a halogenated alkane. But sevoflurane's an ether, desflurane's an ether, and isoflurane's an ether. How do you know that they're ethers? What kind of a bond does it have? The C-O-C bond. A COC bond. So if I were to test you on one of the modern agents, there's only one here that has any metabolism that I would be worried about. What do you think that one is? SIBO. So expect a question on SIBO and its metabolism in the body. If I'm delivering to an elephant, to me, right? If I deliver 6% sevoflurane to myself or to you, to anybody, and I'm telling you that 5% of that 6% is metabolized. Can everybody see that? Because this is 6% of what's coming out of the anesthesia machine. You breathe that in. So you've got 6%. You've got that much in your body. Your body is going to metabolize 5% of that. So how much? It's a small amount, but I think you can see how I can phrase the question. Methoxyfluorine is there for your historical purposes. The same with halothane. It'll be the first year that I'm actually taking halothane off the examination. So if it's a choice, I would pick it. If you want to read about halothane and hepatitis, have at it. They used to be the historical question. But on slide 177, I will test you on this. Why? Because we've got two modern agents here. So let's take a look at this specimen from the rat of liver tissue. So what happened was these rats were exposed to these gases. And then the tissue was harvested, the liver, and antibody staining was conducted. And in this instance, these antibodies were looking for these hepatotoxic substances. In other words, if it stained dark, that was bad for the liver. If it stained dark, that was bad for the liver. Now, when you compare isoflurane and desflurane, C and D, what do you notice? That in this rat preparation, they both increased what? Substances that were somewhat harmful to the liver. Not as much as the other two, the older ones, but it happened. And actually it might be, it's just hard to say from that picture. But the point is they both stained for antibodies in the rat. So what can we say? That des and iso, it might be bad for a rat's liver. We can't say necessarily the same about us, but the point there is it does create harmful metabolites if given in high concentrations or for long periods of time.
So that's the metabolites, not antibodies that stain.
The antibodies stain the metabolites.
Okay.
Yeah. Trust me, when I went to my first neuroscience class, I had no clue about it. Yeah.
So with these rats, was this like, okay, they've been exposed for an hour,
Sure.
or we're keeping them exposed continuously for?
I think for this example, it was 6 hours. But the point there is that these agents are not benign. Here is the importance of MAC hours for you. For your purposes, right here, this slide. So I told you that sevoflurane is sweet, it relaxes bronchial smooth muscle, but if I had to pick a drug, if you forced me to pick a drug that was probably not the best for the kidneys, it would be sevoflurane. Because it does two things. It, when metabolized, 5% of it, forms these fluoride ions in the blood and in the kidneys. And fluoride ions, not real good for the kidneys. The next thing it does is what? It combines with the CO2 scrubber to make this substance called compound A. And then if you have low flows, you breathe this compound A in, and compound A will attack your kidneys. So what you do is you either have flows that carry the sevoflurane higher than 2 liters per minute, or if you're going to use less than 2 liters per minute to carry your sevoflurane, you ensure that you don't go over 2 MAC hours. What does that mean? If I run so flow rate is just what's carrying the gas. I told you that high flow rates, you don't even have to worry about this calculation. If you're over 2 liters per minute, you are carrying enough gas past the circuit, and it's going to escape out of the exhaust and into the scavenger. It's not going to be rebreathed by the patient. But if you're less than 2 liters per minute, you've now entered a semi-enclosed circuit. So the patient can actually rebreathe these compounds. So if you have to have less than 2 liters per minute, you can only run it for 2 MAC hours. So how long could I run 4% SIBO at less than 2 liters per minute?
less than an hour.
About an hour. Right? 4% divided by 2% is 2 Mac. And if I'm only allowed 2 Mac hours at less than 2 liters per minute, then I can only run 1 hour. But what if I run it to around 0.8% sevoflurane? 0.8% sevoflurane. What's that math on the Mac? 0.4 Mac. And if I need 2 Mac hours, it would take me 5 hours to reach 2 Mac hours. Does everybody see that math? Does the introduction of nitrous have anything to do with these Mac hours? No, because nitrous doesn't cause compound A formation. Does that make sense? Think that nitrous could be a distractor on the test when calculating SIBO and compound A? Yes. Probably.
Would not the application of nitrous would increase your flow? So
well, yeah, well, you could run like a half a liter of oxygen and a liter of nitrous. You could do that. But the point there is that the additive MAC has nothing to do with the MAC hours of SIBO in regards to compound A production. When I say antifluorine, you say? All right. Isoflurane, excellent. These are just some review points. I'm almost done. Okay, you guys won't even realize this, but there is occupational safety and hazards requirements for how many parts per million of these agents can be in the air and how many parts per million can be for nitrous as well. And so your OR has to have a certain amount of turnover. And so when I ask you, NIOSH will dictate that if they do an air sample, it has to be less than 1 parts per million for the modern anesthetics, and 25 parts per million for nitrous. Now, what is the issue with nitrous in pregnancy?
Teratogenic effects.
It might be. And what is the enzyme that you should keep at the top of your head? Methionine synthase. And what does methionine synthase create? Methionase, which then goes on to help create DNA. So if you inhibit methionine synthase because of nitrous, then you may inhibit DNA synthesis. One of the first questions I got asked, first week I think, is what is your goal for your anesthetic? You give a volatile anesthetic, you give IV agents. What is the stage and plane? And I looked at him and I was like, what are you talking about? And so, back in the day, this guy, Dr. Arthur Goodell, when he was using ether, he found that the patients displayed these signs as they would move through the inhalation of this ether. And so, stage 1 would be where the patient would be awake but feel better. Stage 2, they would start to get a little agitated, disoriented, combative. And that's the goal, by the way, everybody, is to rush the patient through stage 2. And then you enter stage 3. Stage 3 was your good stage. And stage 3, plane 2, was your best stage. And so what happens? This is your eyeballs and your respirations. So you can see in the second stage how the respirations get erratic. The eyes start to move around and look around. Patient may grimace. They could vomit during this time. They get tachycardic. And then how do you know you're through it? Well, you've kept your gas on, and then the respiratory rate has evened out. the eyeball activity has slowed, especially when you get to stage 2, or plane 2, stage 3, plane 2. The eyeball accommodation has stopped. Now, what happens if you get down to stage 4? You've overdosed your patient. Yeah, they're hemodynamically unstable. And why do a lot of schools won't teach this, but I do, because especially when you're waking up a patient. Has anyone ever had the opportunity to look at the eyes of a patient as they're waking up? So they're disoriented, right? One eye could be looking over here, the other eye could be looking over here. So if I have a lot of eyeball activity in stage 2, and I get out of stage 2 and into stage 1, you will see the eyes come right midline. It's one of the best tools I have. I open up both of their eyes, and I wait till they come midline, and then I tap them on the head. And I say, hey, your surgery's done. It's going to be all right. And what if they just did? They just moved through stage 2. It's really strange to see one eyeball over here and one right down here. And then they come midline. It's really cool.
Is that still true with paralytics on board?
No. Now, that's a whole other ballgame. You'll have to reverse them. Then you could use those signs. Nitrous oxide. What are some of its advantages? So it is not a soluble agent. Right? It is not soluble, sir. It's pretty cheap. It's not a very expensive gas. Doesn't have a lot of metabolism. What will it do to your blood pressure?
Increase.
It's very diffusible, not very soluble. It will actually help maintain your pressures, right? It could cause catecholamine release. What will it do to your uterine activity? It'll offset your.
Help you from being too dilated.
Yeah, it'll actually contract it a little bit. So that's good. But what are some of the bad things about it? I like this chart. It calls sympathetic stimulation like it's a bad thing. I guess it depends. But
Gas displacement when you turn it off.
closed spaces, right? Non-compliant versus compliant spaces. What are the effects? Think about doing cataracts with nitrous. You wouldn't, but somebody's got a bubble in their eyeball, and you run this for 6 to 8 hours. What are you doing to the intraocular pressure? Yeah. So you got to think about those compliant, non-compliant spaces. How about the DNA synthesis issue? Got to be careful with that, especially in the first trimester if you're a rat. And can you give MAC for nitrous? Well, you could if you were in a hyperbaric chamber, but you can't do it at sea level. What about isoflurane? What is an advantage that you could see based in relation to the other two volatile anesthetics?
Very potent.
What's that? Okay, it has minimal metabolism.
It's the most potent.
Of the modern agents, yes, it is the most potent. You think it's also the cheapest? Yes. ISO is the oldest. It is definitely the cheapest. Inexpensive. What about desflurane? What is its key benefit? Quick on, quick off. It is the least soluble modern anesthetic. But what is one of the problems, especially for you guys going to the field? You got to have a special vaporizer. You can't take an electric vaporizer with you. Sevoflurane. Right away, what's its advantage? Induction. Inhalational induction. What is a problem with sevoflurane?
Fluoride.
Okay, which metabolites?
Fluoride.
Fluoride, okay, but that one's like 23 Mac hours.
Compound A.
So compound A is a product of the interaction between the CO2 absorber and the sevoflurane. So how do you compensate knowing that SIVO is going to interact with the CO2 absorber? Higher, keep your flows above 2 liters per minute, or if you keep your flows below 2 liters per minute, what rule should you stick to? Less than 2 Mac hours. Right. Yes?
I have a question back to nitrous. If you think of a Mac of nitrous,
Yep.
that's your like weird situation.
Yep.
Would that mean that the Mac will change or the sigma will change your allocation for these drugs?
The actual Mac won't change, but you bring up a good question. If I'm at Pike's Peak and my atmospheric pressure is, I don't know, we'll say it's 600, okay? And I know that the vapor pressure of isoflurane is roughly 240, 243. And I know that my isoflurane vaporizer will add 8%, or I'm sorry, a percentage, not 8, a percentage to the flows I deliver. So if I'm at 600 millimeters of mercury at altitude, my atmospheric pressure has changed. It's reduced, right? I'm going to add a percentage to the atmospheric pressure. That's what the vaporizers do. So 1% isoflurane at sea level is not the same as 1% isoflurane at altitude. So if I'm 1% isoflurane at sea level, how many torr am I?
760.
Well, I'm 760. So what torr of iso? What's my millimeters of mercury of iso in that 760? 7.6. 7.6 torr. If I'm 1% isoflurane at 600 millimeters of mercury at altitude, what am I there in torr? 6. So my vaporizer output actually decreases when it comes to SIVO and to isoflurane. Aha! But then there's desflurane.
It's pressure.
It is.
So it won't matter.
Well, it actually does matter. Here's why. It adds an actual percent based on a pressurized 1 atmosphere. So
the point of it is it's heated and pressurized in order to maintain it at a.
you're right, but it's assuming it's built to deliver what it thinks is a 1 atmosphere system.
So because it's.
And so when you're at altitude, you actually end up giving more desflurane than you would at sea level. So that's how that special vaporizer affects it. I'm not going to test you on anything I just said. I'm only saying it because but this is a question that will come up again in fundamentals.
Clinically, when you say we're at altitude, at what point would you even start worrying?
Afghanistan.
6,000 feet when you start flying in the back of the ceiling, 30 seconds.
Fort Carson.
But 10,000 is the point where we start losing oxygen. So 10,000 feet is our magic number to start having to do supplemental. So what's the magic number?
Put it this way. Your gases won't act in Denver the way they act in San Antonio. That's all I got, guys.
Thank you.
Is it getting better?
Yes.